Dear Professor Godsby, thank you first of all for reserving time to say some words to our web resource. And my first question is, what is the best medicine today for treating acute migraine attacks?
Best medicine, as we stand here today treating acute migraine, is really the medicine that you tailor to the patient. Some patients will respond to simple analgesics if they've got infrequent attacks. Some patients will need non-steroidals if their attacks are more troublesome and they're suitable. And many patients are going to need high-end therapy, such as triptans. And I think the important thing is to get the diagnosis right, understand the level of disability, and make sure that the treatment's tailored to the individual and tailored to the attacks that they have.
Right. And in migraine prevention?
In migraine prevention, the problem is that we have nothing perfect. We have many options in migraine prevention: serotonin antagonists, the anticonvulsants, which have proved particularly useful in recent years, and of course still the tricyclics. I think matching the side effects and the expectations of the patient to the data we have is the way forward.
Thank you very much.
So I understand.
And what about Tanoberstat? Is it promising?
I'm going to be presenting some evidence in a placebo-controlled trial this afternoon on Tanoberstat for the preventive treatment of migraine. It shows some promise and it's going into phase 2.
What do you think? There is proven that migraine is multifactorial disease, but pharmacological companies go and try to develop very selective drugs. Is it not contradictory to finding better efficacy?
As you say, migraine's a multifactorial disease, and perhaps as we refine our therapies too much, particularly in the preventive side, we might miss out opportunities. I think the refining therapies has contributed to understanding the disorder, but the prospect of losing efficacy in a multi-system complex disorder certainly exists, and we certainly live in challenging times in that way.
Regarding the last report that was presented, what the mechanism is responsible for difference in preponderance, female dominate in migraine and male in cluster hysterics?
I think the gender differences that occur in migraine and cluster headache are going to relate to the hormonal milieu, the hormonal environment that the patients exist in, and the interaction between the hormonal environment and the genetic predisposition that migraine patients or cluster patients have.
And the last question is, what reason and when you decide to link your career to headache?
I'm interested in headache because at a very early stage it was pointed out to me by my mentor, Jim Lance, that there's an opportunity to do a lot of good. And I think there is a lot of opportunity to do good. There are patients who suffer enormously and have considerable disability, and the chance to do something useful about that, I find that very attractive.
I think you do a lot, Professor Godsby. Thank you very much.
Thank you.
I wish you
Thank you.